expected management should be carefully considered. It is considered only in adolescent girls with a stage 1 or stage 2 endometriosis, or in a perimenopausal woman, where we can expect that once they attain menopause, there can be a decrease in the size of endometriosis. But care should be taken for follow up, because these patients are, there is a clear association between endometriosis and endometrioid and clear cell carcinoma of the ovary. Medical management, non-steroid anti-inflammatory drugs can be used to alleviate the pain. Estrogen and progesterone contraceptives, they think that retrograde menstruation is the main theory for endometriosis. If we suppress this for long duration, there can be less retrograde menstruation, and it allows more time for the healing of all the endometriotic implants. That is pseudo pregnancy regime. Minimum of 3 months, there is 90 days it should be continued, or it can be continued as long as the patient wants, till the patient may get a breakthrough bleeding. If the patient gets a breakthrough bleeding, then we can have a pill free period for 7 days. Suppose patient wants uh, continued, then it can be treated by giving estrogen, medroxyprogesterone 30 to 100 milligram, or injection 150 milligram every 3 months. It can be done. Suppose the patient doesn't want to discontinue the medication and she wants to continue, then breakthrough bleeding can be treated by conjugated estrogens 1.25 milligram or estradiol 2 milligram for 7 to 10 days. Norethindrone acetate, that is estrogenic progesterone, also can be tried to prevent the breakthrough bleeding 5 to 15 milligram, or megestrol acetate 40 milligram for 7 to 10 days. Suppose the patient doesn't want to take tablets every day, LNG IUCD also can be used in some patients to alleviate the symptoms of endometriosis. Care should be taken that as long as the estrogen is suppressed, these patients are prone for bone mineral density deficiency. So they should be scanned for bone scan to see that bone mineral density. If it is less, they should be treated specifically. Denogest, it needs a special mention because it is a progesterone derivative, and it is useful even in a progesterone resistant patients. It can be used 2 milligram or 4 milligram, and it will very well effectively alleviate the pain symptoms as long as the patient is taking the medicines. But once it is stopped, the recurrence of symptoms is prompt. GnRH agonist, where they substitute the D amino acid at 6th position to L amino acid. So they will act for longer duration. So whenever the GnRH agonists are stimulating this receptor for longer duration, there can be down regulation of the receptors. The down regulation is so much that there is a complete deficiency of LH and FSH in the body, which can lead to all menopausal symptoms. So they need to be treated with some amount of add-back therapy. Leuprolide, nafarline, goserline, buserline, triptorelin can be used. They should be started 1 week prior to the expected menses. Norethindrone acetate 5 milligram or conjugate estrogen medroxyprogesterone can be used as an add-back therapy in these patients. So always use progesterone along with the estrogen. The leuprolide gives efficacy of nearly 90%. GnRH antagonist also can be used. Here there is no flare effect and there is no need to use add-back therapy because they dose dependent suppression of LH and FSH is there, and it can be used as much as you want, and there is no loss of bone mineral density because suppression is not complete. We can have a very well control over the amount of suppression that is necessary. So elagolix 150 milligram per day or 200 milligram twice daily can be used. Aromatase inhibitors are second line drugs. Anastrozole 1 milligram per day, letrozole 2.5 milligram can be used. They can be used along with GnRH agonist, or they can be used along with norethindrone acetate or combined oral contraceptives. Specifically, aromatase inhibitors can produce headache, joint stiffness, and hot flushes. They are not primary method because they do not suppress LH and FSH. So bodily there is increased LH FSH in these patients. They only prevent production of estrogen from androgens. So they can be used along with the other medications.